in the last class, we have discussed regarding narrow QRS tachycardias. What are the different narrow QRS tachycardias and how will you differentiate each type of tachycardia? What are the classification? How will you know that it is an SVT? How will you know that it is an atrial fibrillation? How will you know that it's a multifocal atrial tachycardia? And all those things we have discussed. Now today we'll go into the algorithm as such. See, now what you have done is that you have understood that this patient is having a tachycardia. So whenever you see a tachycardia, the next question that arises should arise in your mind whether the patient is stable or unstable. So that is the next question that you need to answer. So any tachycardia, whether it is stable or unstable, the treatment is totally different. So the treatment depends upon the patient's stability. So that is the first thing that you need to remember. So any tachycardia that you see, the next thing that should arise in your mind is the patient stable or is the patient unstable. If the patient is unstable, the treatment option is different. The patient is stable, the treatment options are different. So that is the first thing that you need to remember. Okay. So what we have done, we'll just go start with the algorithm here. So this is the adult tachycardia with a pulse. So the patient is having a pulse. It is not in cardiac arrest. If it is in cardiac arrest, we have already discussed shockable rhythms, VF and VT we have already discussed. But here it is an adult tachycardia with a pulse, and our question to be answered is whether the patient is stable or unstable. So let's start from here. So we have a patient who is having a heart rate of more than 150. So as I told, usually less than 150, it will be sinus tachycardias usually. But whenever it goes beyond 150, there is some abnormality is there. So it can be an SVT, it can be an atrial fibrillation, all those things whatever we have discussed, it is a possibility. So that is the next thing that you need to remember, heart rate more than 150. So identify and treat the underlying cause. You remember maintaining patent airway. So that is again, hypoxia can cause tachycardia as well as bradycardia. So you have to make sure that the airway is patent, like we did for our bradycardia algorithm. The whole goods the same. Maintain patient airway. If needed, the patient is not breathing well, you start with back mask ventilation. Oxygen, if the patient is hypoxic, if the saturation is less than 92%, you supplement them with oxygen. Then the next thing is that connect to a cardiac monitor, which is the same thing what we have done in our bradycardia algorithm also. Connect to a cardiac monitor, then what we have done, connecting to a cardiac monitor, then saturation and blood pressure monitoring. These are the things that we have done. So these are the things, next thing, and get an IV access. If you don't have an IV access, get an IV access and 12 lead ECG. See, 12 lead ECG is always helpful for our differentiating type of tachycardia. We will be able to see the rhythm in the rhythm strip. But when you take a 12 lead ECG, we can see whether there is an associated myocardial infarction also. See, myocardial infarction can also have tachycardias. So we wanted to know whether there is any acute STT changes is there or not. So this is the same for our bradycardia and tachycardia algorithm. So whatever we have done, we have given oxygen to the patient, we have given corrected the hypoxia, we have seen the blood pressure, everything. And if there is hypotension, we need to give IV fluids. Basically, hypotension can cause tachycardia. So hypotension is associated there, you have to give them IV fluids and bring up the blood pressure. So the heart rate will come down. So even after doing that, there is persistent tachyarrhythmia. So that is the next question. The patient is having persistent tachycardia. So persistent tachyarrhythmia. So what we have done, we had a patient whose heart rate was above 150. What we have done, we have made sure that airway is fine. If there is airway issue, we have given him assisted ventilation, then breathing, then circulation, connected to the cardiac monitor and assess the patient and get an IV access, and also we have taken a 12 lead ECG. So after that, the patient is having persistent tachycardia. Then we have to see whether the patient has got any signs of to call whether it is an unstable tachycardia. So we have already discussed what are the signs of unstable tachycardias. It is hypotension. The first one is hypotension, altered sensorium, signs of shock, ischemic chest pain and acute heart failure. Any of these signs are there, then we have to label this patient as got an unstable tachycardia. So we have a patient who has come to you with a tachycardia, heart rate more than 150. What we have done, we have connected ABC, we have continued with the assessment of ABC, connected to a cardiac monitor, put an IV access, blood pressure monitoring has been done. And what you have done that, we have seen that whether there is any signs of unstable tachycardia, to call it as an unstable tachycardia, like we call it as an unstable bradycardia. Similarly, due to decreased organ perfusion, that tachycardia is causing some problems in the perfusion, like altered mental status, hypotension, signs of any other signs of shock. Then the next thing will be what? Ischemic chest pain and evidence of acute heart failure. If it is there, then it is an unstable tachycardia. So remember that whenever you have an unstable tachycardia, okay, unstable tachycardia, the treatment is synchronized cardioversion. What is the treatment? Whenever you have an unstable tachycardia, the treatment is synchronized cardioversion. See, depending upon the, now we have to see what we have done. We have a patient who had come to you with tachycardia, ABCD is done, and we have seen that this patient is unstable. So once the patient is unstable, we are preparing for synchronized cardioversion. So we have decided that this patient needed a synchronized cardioversion. So if the patient is having a synchronized cardioversion, what you have to remember is that the patient needed to be sedated. So that is the first thing. You cannot just go and shock the patient just like that. So what we have already discussed this. We have a defibrillator machine like this. So where the sender, there will be the rhythm that you can see. You will be able to see the rhythm in the center, and you will have a sync button and a shock selection button. So most importantly, you have to press the sync button. So once you press the sync button, what will happen? No, ECG leads are, suppose there is tachycardia. Just I am, for the purpose of demonstration only I am writing. It is a BF, but just for the purpose of demonstration I have written because space is very low. So when you press the synchronized button, what will happen? No, a small arrows will start coming in over the QRS complex. So the machine is identifying the R wave, and over the R wave only the machine is going to deliver the shock. Because if it is not delivering the shock at any other point, the patient can go into further worsening of the arrhythmia. So during the refractory time only, the patient need to be, during the peaking of R wave only, the machine need to identify and deliver the shock. For that purpose, when you press the sync button, a small line will come over near the R wave. So peaking of the R wave, you will be able to see a small line. So that is when you have to make sure that the patient has gotten synchronization is on. So now the question arises, what is the joule amount of energy that you need to deliver? So in defibrillation, it is very clear. It is the maximum joules or 200 joules you are given. But here, the patient is not in cardiac arrest, but the patient is having an unstable tachycardia. So you have to remember unstable tachycardia. This patient is having unstable tachycardia. So that you have to decide, and you have to go ahead with synchronized cardioversion. So what is the synchronized cardioversion? So once you have decided for synchronized cardioversion, what is the first thing? You have to sedate the patient. So that is the first step. The drugs can be, you can give morphine, you can give midazolam, fentanyl. These are all agents that can be used for sedation. So midazolam, morphine, fentanyl, these are the drugs that can be given. You have to sedate the patient. Next thing is that, what you have to know that, we have to see whether it is a wide complex or whether it is a narrow complex. So what you have seen, we have patient got an unstable tachycardia. Now we have to decide whether it is a wide complex tachycardia or whether it is a narrow QRS tachycardia. See, whenever you see that this patient is unstable, there is no role for drugs. The role is synchronized cardioversion. So we have to select the amount of energy, we have to press the sync button, and you have to shock the patient. Okay, that is the only thing when the patient is unstable. So once you say that the patient is having an unstable tachycardia, next question is that we have to see whether it is a wide complex or whether it is a narrow complex. If it is a wide complex tachycardia, you need to start with 100 joules. See, wide complex irregular you won't see here, because wide complex irregular is ventricular fibrillation. That you will see only in cardiac arrest. So wide complex tachycardia, what we will see here is ventricular tachycardias. So 100 joules, you can start with 100 joules. So what you have done, you have to sedate the patient, and you have to synchronize press the synchronize button, and you have to give synchronized cardioversion for a wide complex tachycardia, unstable wide complex tachycardia for 100 joules. Now come to the narrow QRS side. So narrow QRS side, what all options you have? You can have regular and irregular. Okay. So if you have an regular and irregular, unstable, narrow QRS tachycardia, again the treatment is synchronized cardioversion, but only thing is there is a slight joule change. So for it is regular, you can start with 50 to 100 joules. If it is irregular, it is 120 to 200 joules. So basically this is SVT, right? Narrow complex regular is SVT, no? Because sinus tachycardia above 150 we will not call. So basically it is SVT, and this is atrial fibrillation or multifocal atrial tachycardia, any of these things. So I'll just come back to this algorithm again because little bit confusing for you. So you have seen a patient is having heart rate above 150, ABCD done, 12 ECG done. If the patient is unstable, the next question that you should come in your mind is that whether this patient has got a wide complex tachycardia or a narrow complex tachycardia. Wide complex 100 joules, synchronized cardioversion. Narrow complex you have two times, regular and irregular. Regular 50 to 100 joules and irregular 120 to 200 joules. So what are the tachycardias we have already discussed. See, certain point of time, no, whenever you feel this patient is even if unstable, okay, even the patient is unstable, you are saying a narrow QRS tachycardia, you can try adenosine, but I'm just remember that whenever there is an unstable tachycardia, the treatment is synchronized cardioversion. So you remember that for the time being, okay. So that is the first step that we have done. Now, tachycardia persisting, you have to go ahead with synchronized cardioversion. Then you have to treat the underlying cause. Why this patient is having a tachycardia? What is the reason? Whether it's a sepsis, myocarditis, whatever be the reason, whether it is a primary myocardial infarction, any other drugs that you need to give. Sometimes you need to add on certain drugs like amiodarone. Any of this you have to discuss after that. But once you decide that this patient is having an unstable tachycardia, the treatment is synchronized cardioversion. That you have to be very clear. Now, what we have to do is that the patient is stable. Okay. Now, the patient is what we have discussed unstable. Now, the patient is stable. So, stable again can have what all? Stable you can have again two limbs, right? You can have wide complex tachycardia and narrow QRS tachycardia. Among in narrow QRS, you can have again regular and irregular. Clear? So, we will take first one, wide complex tachycardia, stable. What is it? Wide complex tachycardia stable. What will it be? It will be ventricular tachycardia. It will be otherwise ventricular tachycardia. What you have to remember is that the drug of choice here is amiodarone. The drug of choice is amiodarone 150 mg IV. So, wide complex tachycardia stable. So, I am telling you again, stable wide complex tachycardia, the treatment option is amiodarone. Or there is another agent, just you can remember these names. I don't want you to by heart their dosages because routinely we don't practice here. So, there are other drugs called procainamide. These are all antiarrhythmic agents. Other agent name is what? Procainamide and sotalol. Clear? Okay. So, once again I will say, okay, you have got a stable wide complex tachycardia. Amiodarone is the common agent that we use. Dose of amiodarone is 150 mg. Then you have to remember this. You have to start as an infusion. Once you give this bolus, you have to continue as infusion of 1 mg per minute into 6 hours. Then 0.5 mg per minute into next 18 hours. You have to continue amiodarone infusion. Initially, give a bolus of 150, followed by 1 mg per minute into 6 hours, then 0.5 mg into per minute into next 18 hours. So, total 24 hours you need to give infusion. So, that is regarding your amiodarone. We can use other agent called as procainamide, and you can give sotalol also, but you don't remember those doses. That is fine because routinely we don't use those drugs. So remember regarding amiodarone 150 mg IV stat followed by 1 mg per minute infusion for the first 6 hours followed by 0.5 mg per minute per infusion for the next 18 hours. So that is the dose of amiodarone. So that's it for your wide complex tachycardia which is stable. Now we have to go ahead what? We have an that side narrow QRS tachycardia which is stable narrow QRS tachycardia. That is what we are discussing. So stable narrow QRS. Okay. So again it can have a regular and irregular. So if it is regular, it is otherwise what is called as SVT. Regular is SVT. So SVT what you can try? You can try something called as vagal maneuvers. There is something called as vagal maneuvers. Vagal maneuvers. The most common preferred one is carotid sinus massage. So when you have to do for a narrow QRS, regular, stable tachycardia. So there are otherwise SVT. So you can do vagal maneuvers. The most important one is carotid sinus massage. While doing carotid sinus massage, certain things that you have to be very clear. You have to auscultate the patient to look for any carotid bruit. Because why bruit? Because both the sides there are carotids. There are carotids like this. So imagine there is a thrombus here. Okay, there is a thrombus on this side of the heart, on this side of the carotid. So when you give a massage like this over this area you are giving a pressure. Okay, over area. What will happen? This thrombus can get dislodged and patient can develop a stroke. So if there is a flow limitation, use the stethoscope and keep it over the carotids and you see whether you are able to hear any bruit. Bruit means when you have a pipe. Okay, there is a block inside the pipe. There will be some turbulence flow. You will be able to hear. That turbulence flow is otherwise called as bruit. If there is carotid bruit, you should not. If there is carotid bruit, you should not do carotid sinus massage. So that's the first thing that you need to do. You have to rule out that there is no carotid bruit, and after that you have to do a carotid sinus massage. And how to do a carotid sinus massage? You auscultate it. You see, this is the angle of the mandible. This is the angle of the mandible, and just below that is the carotids. So just use your two fingers or you can use your thumb also and gently massage over that area for 5 to 10 seconds. So make sure that you are connected to a cardiac monitor, all your resuscitation equipments are ready because the patient can go suddenly into bradycardia. So patient should be lying down in a bed, then only you should be doing this. So the first thing that you can try is called as carotid sinus massage. So carotid sinus massage, if the carotid sinus massage fails, okay, so the failed carotid sinus massage done, still the patient is having SVT. So what do you have to do? You have to give a drug called as adenosine. Adenosine is the drug that you can give and it should be given initial dose for an adult patient is 6 mg IV stat. It should be given as a rapid infusion. Why? Because it has got a very small half-life. Few seconds is only its half-life. It will get degraded. So what you have to do? You have to put always in a cubital line, cubital fossa. The patient is having a center line, only half the dose is needed. But if the patient don't have a center line, you have to put in a cubital fossa. Give the drug and give 20 ml saline flush also and raise the limb so that the drug will reach the heart much faster. And while giving the drug, you have to make sure that all the crash cart medications are ready because the patient can go into bradycardia. So the first drug that you can give is adenosine. If the vagal maneuvers fail, you can give adenosine 6 mg IV stat. If still the patient is having tachycardia, you can give 12 mg. You can double the dose and give. So that is the dose of adenosine that you can remember. The next thing that you have to do is that, so what we have discussed, we have an narrow QRS tachycardia. We have tried first what? We have tried vagal maneuvers, vagal adenosine, 2 doses you are given. Still it is refractory. You can try any of the calcium channel blockers, beta blockers or even amiodarone. Examples of these are calcium channel blockers is diltiazem. Beta blocker is metoprolol. So you can try any of these drugs. So that is regarding your narrow QRS regular tachycardia. So narrow complex, regular tachycardia. Now the next thing is what? Narrow QRS, irregular, or AF, or multifocal atrial tachycardia, irregular, but the patient is stable. So what is the drug of choice? Again it is amiodarone. Similarly 150 mg, then 1 mg per minute into 6, then 0.5 mg per minute into 18. So amiodarone can be used. Or else you can have any other drugs that can decrease the heart rate, like calcium channel blockers or beta blockers. Calcium channel blocker example is diltiazem, verapamil. Beta blockers common example is metoprolol. So these are the drugs that can be used. So that in a nutshell completes your tachycardia management. So we'll come back to this tachycardia again. So you had a patient who is having a heart rate above 150 beats per minute, ABCD stabilized, taken a 12 lead ECG, and after that what you have done, you have seen whether this patient is stable or unstable, and if the patient is unstable, the treatment is synchronized cardioversion. So depending upon the type of tachycardia, the dosage, there is some subtle differences. The patient is having a narrow QRS irregular tachycardia, which is unstable, which is atrial fibrillation, you have to give 120 to 200 joules. Narrow QRS regular tachycardia, which is SVT, start with 50 joules, 50 to 100 joules. Then you have wide complex tachycardia, which is regular ventricular tachycardia, give 100 joules. So that is the dosage for synchronized cardioversion. You have to press the sync button. That is a priority, and the patient need to be sedated also. Coming to this side, that is stable. The patient is stable. You can have wide complex tachycardia stable, amiodarone 150 mg per minute, 150 mg stat, followed by 1 mg per minute for the first 6 hours, then 0.5 mg per minute for the next 18 hours. There are other drugs like sotalol and procainamide which also can be tried. That can be tried for narrow QRS also, but the most common one what we have to remember is that what we use it for is the amiodarone is what we commonly use. Then coming to this side, narrow QRS regular, start with stable, vagal maneuvers, carotid sinus massage, rule out a carotid bruit. Next thing, you can give adenosine, stat 6 mg. Then you can give another dose of adenosine, 12 mg, that is the next dose. Fails, calcium channel blockers or beta blockers you can give. If the patient is still having, then you can try a amiodarone also. Then we have narrow QRS, irregular tachycardia, the patient is stable, amiodarone, calcium channel blockers or any beta blockers. So that is in a nutshell. So approach to tachycardia means this yesterday's class and today's class, you need to remember and discuss the whole thing. Okay, thank you.